So hello, everyone. Welcome to the HRSA EHE Office Hours series. My name is Sarah Palmer. I'm a manager on the Health Systems Integration team at NASTAD. Today is session 3 of this series, and we'll be focusing on engaging state and local health departments. Next slide, please. So a quick disclaimer before we begin. So this project is supported by HRSA as part of our cooperative agreement. Does not necessarily reflect their views. Next slide, please. So here's the agenda for today's session. So we're going to start with a few polls to get a sense of who's in the room and what your experience is with collaborating between state and local health departments. Then I'll give a brief overview of NASTAD and the EHE SCIP team in case you're not familiar with us. Then we're going to hear 2 examples from EHE jurisdictions that have successfully collaborated between their state and local health department. So first, we're going to hear from Arizona Department of State Health and Maricopa County Department of Public Health. Then we'll hear from the City of Detroit Health Department on their Data to Care RX program. So we'll save plenty of time at the end of the 2 presentations for Q&A for the presenters. And we'll also have a large group discussion about your successes, your challenges, and any opportunities you may have to improve your collaboration between state and local health departments. I'll also share a few best practices to keep in mind as you move forward to collaborate further with your state or local health department. And then we will wrap up and share an evaluation at the end. Next slide, please. So before we begin, a few housekeeping items. So today's session will be recorded. The recording and the slides will be shared after the meeting. So this is an interactive meeting, so please feel free to use the chat for any questions you have during the presentation. And then at the end, we'll open it up for a large group discussion. Self-care, please feel free to do what you need to do to take care of yourself. Take a stretch, get a water, get a coffee. We know Zoom fatigue is real, and we have back-to-back meetings too, so we totally understand. Do what you need to do to take care of yourself. And then finally, feedback. So at the end of today's session, we will share a brief evaluation survey. And if you could take a few minutes at the end of today to fill out that survey, we would really appreciate that to get your feedback to improve future sessions. Next slide, please. All right, so to get us started today, I have a few Zoom polls. So this is going to give us a sense of who's in the room. So we want to know if you represent a state or a local health department, if you currently collaborate with your respective state or local health department on any EHE efforts, what are the barriers to collaborating more frequently, and what have you successfully collaborated on? So give me just a second, I will launch these polls for you. Okay, that should be launched. So you should see 4 questions on your screen. And I'll give you about a minute or 2 to complete those questions. Awesome. Starting to see these results roll in. Thank you so much for everyone who's participating in the poll. Give it another minute or so to give everyone a chance to complete it. Okay, so it looks like we have a pretty even split on number 1 so far. We got a little more coming in now. So it looks like most people here right now are from local health departments, few from state health departments, and a few from other. Okay, and then on number 2, do you currently collaborate? It looks like most people did say yes often or yes sometimes, so that's really great to hear. Okay. What have you successfully collaborated on? Looks like a lot of people collaborate on EHE planning, which is awesome. So we'll definitely talk about that today, as well as data to care activities we'll talk about today too. Few said CDR activities, few said eligibility, leveraging funding. Okay, it's great to see, thank you. And then the last one, what are the barriers to collaborating frequently? Looks like most people said competing priorities, which is definitely understandable. And then second most was staffing limitations. Yes, we hear that a lot too. We have a few people saying budget or lack of willingness to collaborate. Okay. So thank you so much for participating in that poll. That gives us a really good idea of who's here and what you may be interested in learning today. Okay, go ahead and end the poll here. Okay. So now I'll take a few minutes to share a background about NASDAD if you aren't familiar with us. So NASDAD is a nonpartisan, nonprofit association that represents public health officials who administer HIV and hepatitis programs in the US. So we serve governmental public health agencies across states, territories, and local jurisdictions. And we do this work by strengthening governmental public health through advocacy, capacity building, and social justice. Next slide, please. I'll give a brief background on my team as well, which is the EHE SCIP, or Systems Coordination Provision Team. So we provide technical assistance on the integration of healthcare services. So some examples on the screen of the types of TA we provide, including leadership development, learning collaboratives, communities of practice, and peer-to-peer learning. And a few of our areas of TA expertise are listed on the bottom. So that would include things like data sharing, program policies and procedures, procurement, developing innovative programs, and stakeholder engagement. Next slide, please. Here's our beautiful headshots. Here's our friendly faces of the team. So you can feel free to reach out to us with any TA needs or any questions you may have. Next slide. Okay, so before I turn it over to our presenters, one last thing. So I wanted to set the stage on what we're here to discuss today. So collaborating between state and local is crucial to the success of EHE. And we saw in our poll that a lot of you already do that, which is great to hear. So by working together, you can achieve more to effectively tailor your programming to your specific populations. And a few of the opportunities you may have are to mobilize your programs across different levels, across state, across local, to leverage your federal resources in a new and creative way, or maybe to identify some policy changes that may be needed at the state that could impact the local. And there's a lot of other opportunities as well that we'll have our presenters discuss today. So next slide here. So now I want to turn it over to Jeremy and Isabel in Arizona to talk a little bit about how they collaborate. Thank you.
Good afternoon, everyone.
Should be.
I am Jeremy Hebard and I use he, him pronouns. I am the Ryan White Subdivision Manager here at Maricopa County Department of Public Health. Isabel, do you want to introduce yourself?
Absolutely. Hi, folks. My name is Isabel Evans. I use she, her pronouns, and I am here at the Arizona State Health Department, or the Arizona Department of Health Services. And I am our Ending the Epidemics Program Manager within our Office of HIV and Hep C Services, which means I handle special projects for our HIV and Hepatitis C teams. Back to you, Jeremy.
Thank you. Next slide. So just a quick kind of overview of our different programs. So Isabel at the state, at the Arizona Department of Health Services, works out of the Office of HIV and Hep C Services. So as you can see, they have got HIV surveillance, prevention, both the Part B and the ADAP programs there, as well as hepatitis C, and the program that she works and oversees is the Ending the Epidemics program. And then here at Maricopa County Department of Public Health, underneath the Ryan White subdivision, we have both Part A and Ending the HIV epidemic funding. So that kind of is the makeup of our area here locally. Next slide. So we coordinate a lot. And as you'll see on many of the things, everything we're presenting on, we've done some coordination on, at least a little bit of coordination on this past year. But this is all very much ongoing work that we've been doing for many years. So what makes it easy for us to coordinate here in Arizona is, one, the physical proximity. Our offices are in the same city. Pre the pandemic, we were like less than a mile from each other, actually. We recently moved to another location. It's a little bit further away, but still very easy for us to physically be in the space together because we're in the same city. We also have a significant amount of population overlap for people with HIV. 2/3 of all people with HIV in Arizona live within the Phoenix EMA, so that in the Part A jurisdiction. And then also of the 500 plus individuals that the Part A office serves, almost a vast majority of them are also utilizing ADAP services. We also share a lot of contractors too, and many of our contracted agencies are duly funded by both of our programs. We also have some staff overlap. My boss used to be, who was the Part A program manager before me, was the Part B program manager at one point. So we have some staff that have worked in both offices, so we're very familiar, and that has created even better connections across our programs. And I also kind of already touched on this, ADAP overlap. You know, ADAP does sit with Part B at the state, but it covers many of our clients. And then we also have a genuine desire to coordinate and collaborate to just improve the care and services that we offer people with HIV and work to end the HIV epidemic. Next slide. All right, so here are just some of the examples of the ways that we coordinate. So we're going to talk today as we go through this about our joint eligibility work, our work on our Ryan White portal, which is our online application portal that launched for clients earlier this summer. We also have integrated planning work that we do together, needs assessments for specifically our every 3-year comprehensive needs assessments. And then we're also have begun this past year really working closely together on cluster detection response activities. Next slide. All right, so I'm going to talk about joint eligibility to start. So this, as you can see, this timeline goes back quite a ways. So going on, this is now 20 years in the making. Don't let that daunt you. If you're not doing joint eligibility, it can be done faster. But we here at the county in the early years in 2005 to 2007, work to move everything to a centralized careware system for our Part A services and providers. And then in 2007, launched our first implementation of centralized eligibility in Part A, the Part A jurisdiction. So clients only had to do eligibility at one location, and then they were eligible for all services. And then in 2011 to 2013, ADHS did the same thing with their programs. They centralized their careware, and then they migrated ADAP to careware. And then we started working on some data integration between the systems. So there's a lot of sharing of data, but we were still very much separate systems at that time, but their systems were allowed to talk to each other and share data back and forth. And then in 2016, we developed our first version of our statewide eligibility policy and launched the following year an online eligibility processing system called RWISE. So it wasn't a system that didn't have an application part of it, but our programs could process the eligibility in there, and that was shared across. And then finally, in 2018 to 2020, we migrated, ADHS migrated to JProg, Amazon web-based cloud hosting. And in 2020, we, after I think 8 years of working on this or trying to get this happen, finally got our legal departments to agree on a data sharing MOU that was finalized. And that year, the Part A jurisdiction joined that Amazon web-based cloud hosting server, and we had one careware launched for the whole state. So all of our systems at that point were integrated under one hosting and allowed us to even further collaborate and data share across the systems. Now, ongoing beyond this, that's kind of the meat of how it all started and got here into where we're at. We do meet at least monthly to review and make updates to eligibility, identify barriers that are happening, and try to work to streamline those. So we're continually adjusting the policy as needed. For instance, when HRSA allowed us to move to annual eligibility renewals, we were able to do that within a few months because the systems were so intertwined and because the policy was already fleshed out. It was really just a few edits and some back-end work that allowed, and we were able to pivot really quickly to make that happen. Next slide. So I've kind of already mentioned this a little bit. So that all laid the groundwork for what we are currently doing. And this has been a massive project that we've been working on for 7 years. There's reasons why it took that long, but we were finally able to last summer in 2023 to launch the staff version of the Ryan White portal. So we let it go for a year with case managers and eligibility staff and ADAP staff to be able to work out kind of some of those back-end kinks and processes. But we built this portal so that clients can now, as of this past summer in July, clients are now able to apply online for our services. And the reason why this platform is so important is because we do also have a lot of individuals who move from, say, Phoenix in the Part A jurisdiction to Tucson in the Part B jurisdiction. And so this system more seamlessly allows us to transfer their eligibility once we have, the residency updated and that stuff. So this really does process enrollment and renewal processes. It has automated reminders now for clients to send them emails to let them know about that they're due for eligibility renewal or what's missing, which we didn't have in the past. We were doing that all by mail, which proved tricky, but now we were able to do it by email as well, and it's working really well. Many of our clients have already begun transitioning to do this. And then also the state created with input from our program and from many of our providers and clients, informational step-by-step client-facing videos that they can watch to walk them through how to apply online. And then they provide ongoing training to staff, so case managers, early intervention workers, eligibility staff, so they are informed of how to use the portal and any updates that happen. That's all for me. I'm going to turn over to Isabel for the next slide.
Absolutely. Thanks, Jeremy. And if those were two really big data projects that felt very overwhelming, I'm going to talk about much more touchy-feely stuff now, since I do not anymore live in the Ryan White world. I'm here doing special projects, but I'm going to bring up the rear here with 3 more examples of how we work together. The first is our integrated plan, and this started long before I showed up in Arizona, but in 2017, our 2017 to 2021 plan was integrated statewide, and we did that again with our integrated plan that was written for 2022 to 2026. So we had our statewide HIV prevention team, we had our Part B, our Phoenix EMA, our ADAP, and our Las Vegas TGA, which not only do we collaborate really closely here at the state with Jeremy at Part A here in Phoenix, but we also chat with our Las Vegas Part A folks as well very often, and they're also built into a lot of the data systems that Jeremy was just talking about, which is fantastic. We've got our statewide Hep C and STI control team, and so for our 2022 to 2026 integrated plan, we were able to bring together all of these partners to write one statewide plan. One of the pieces that actually allowed us to do this was that our EHE funding was a little unique here in Arizona. As Jeremy mentioned, EHE funding that we got about, 4 or 5 years ago now, the Ryan White side of that, the HRSA side of that, did go to Jeremy with the county for the Ryan White Part A. However, there is not a CDC-funded HIV prevention team in Maricopa County, and we actually have very limited public health staffing at the city of Phoenix, even though we're a really, really big city. So the HIV EHE money from CDC came to the state health department. So when we had to write our EHE plan in 2020, which may be very familiar to many of our local EHE-funded partners on this call, we had to work together because one of us had gotten the HRSA money and one of us had gotten the CDC money, but we needed a plan together. So the great news was that we were able to take our EHE work and mold it into our integrated plan. We used the pillars, and we were able to build on a lot of steps, our 2017 to 2021 plan, our EHE plan, and these ongoing conversations about joint eligibility and data systems integration to build an integrated plan. ADHS leads our integrated planning effort since we are the statewide HIV prevention organization here in Arizona, but we worked with Ryan White Part A staff members and planning council members and clients at every step of the way for planning. I think this is really important. We didn't just sort of let them know we were doing it and say, we'll send you the email. They were really involved. They were informed about next steps before anyone else. They were allowed to say, hey, this doesn't work for us, or can we change this timeline? And their staff members and their clients were included in our work groups for each pillar, in our oversight committee that provided the high-level guidance, and in our internal discussions. I think it's really important that as we built our integrated plan, our Ryan White Part A team was treated more as another program at our state health department instead of an external partner that we gave updates to occasionally. And Ryan White Part A continues to be included in our improvements in monitoring. We often include, or actually we have always included in the last 2 years in our improvements, at least one Ryan White Part A staff member and our planning council chair, which I think really helps to ensure that our Ryan White Part A voices are heard in our state planning processes. We expect to do this again for our upcoming plan in 2027 to 2031. And we find that having an integrated plan is a great way to keep us on the same page, to reduce duplication of efforts, and to also ensure that we have a way to work together to set goals that is not just about our grant deliverables or what we're bringing back to our funders. Next slide. Okay, so in terms of integrated plans, if you've worked on an integrated plan, you know that you also need to do a huge needs assessment. And if you work in Ryan White, you know that our every 3-year requirement pops up very frequently. 3 years goes by really quick to also do surveys of clients. So here in Arizona, we have tried to streamline these efforts and make our work make more sense. So in 2021, we completed our every 3-year survey for Ryan White Part A and Ryan White Part B, and it also informed our integrated plan. So we built it out a lot broader than just our HIV care. We also had an HIV prevention survey so that we could utilize this for not just our Ryan White requirements, but also for our integrated planning requirements. And it was statewide because, as Jeremy mentioned, folks move around a lot. And because Phoenix EMA covers such a huge part of the state, it has to be considered when we talk about Part B, even if it's not technically our jurisdiction. So HIV Care Survey for 2021 was developed in real close partnership by ADHS with our Ryan White Part A staff and one of the subcommittees of their planning council, CHIPS. It didn't include PSRA questions. They did separate PSRA that year, but we were basically in calls all the time. The level of, sending drafts and getting comments back from CHIPS members and updating it and then having internal meetings and sending more drafts. This wasn't a, hey, we'll let you know when it's done. This was a, we're working on it every step of the way together. When we finished the survey, the state health department was able to share the raw data with Ryan White Part A for their own evaluation and analysis, because sometimes they want to run different stuff than we do here at the state, and that also allowed them to pull out just their client data and do analysis for their jurisdiction. Now we're in 2024. Instead of doing a prevention survey and a care survey, we're doing one big survey. It's for HIV, STIs, and Hep C. It's been a little bit wild. And once again, it's been developed in partnership with Ryan White Part A staff and CHIPS subcommittee members. I literally sent an email today to the CHIPS subcommittee, Ryan White Part A staff representative, because they're meeting literally right now, and I'm here with you instead with all of our updates. I'm on their call every other month to give updates, to talk to them, to share with them. And I think, once again, the important part about this for us is that our Part A members are getting information at the same time that our internal state programs are. They're not hearing it as an external partner later on. This year, we're even including the PSRA questions for Ryan White Part A in our survey, so we reduce duplication for clients, because we know that our ADAP clients overlap with our Ryan White Part A clients. Our Hep C clients might overlap with our Ryan White clients. Folks move jurisdictions, all that good stuff. And once again, we'll be able to share the raw data directly with Ryan White Part A for their own evaluation and analysis. And I think one of the reasons we're so comfortable with this is because we already work in shared data systems. There's really a strong level of trust and understanding between our programs that if I send them a bunch of raw data, it's all going to be okay. And they're going to let me know if something crazy comes up, and they're not going to post something or publicly put something in a newspaper that's going to make my life difficult. We have a real strong shared understanding and trust of how we use our data. So we're much more comfortable sharing things among ourselves and having really in-depth conversations. Next slide. So our last example of collaboration is cluster detection response. As Jeremy mentioned, this is actually a little more recent. Back in prior years, 2019, 2020, CDR was developed here at the state by our HIV surveillance and prevention teams. They developed a plan to meet CDC requirements with the new EHE funding, and we started sharing some awareness and some content at our symposium that we also host jointly. We didn't even put that on here, but training and events is something we also collaborate on. And our activities regularly occur at the state health department as required by CDC. I think CDR comes up as something very often for state and local jurisdictions that can be really tricky because most of the data for CDR is often housed within HIV surveillance systems at state health departments, but local jurisdictions might have, a real need to work on CDR and to speak to their communities directly about this. In 2024, during this past year, we started receiving technical assistance from NASTAD to actually improve our response portion of the CDR plan. We were finding that the surveillance pieces were growing really, really well here at the state, and those are kind of, internal to our HIV surveillance and prevention and DIS programs, but we weren't doing a great job of bringing others in. We found that people were often misinformed about what CDR was. They didn't really know what their role was or what the state was doing, and that was creating some apprehension, and even our partners didn't have a really great sense of what we were doing. CDR is really hard because the state can't just share surveillance data with everyone, so we decided that we were going to do a better job of working on our plan to dictate what would happen during response, how we'd share information, and what this would actually look like in Arizona. In May this past year, or I guess during this year, so about 6 months ago, ADHS and NASTAD hosted a 2-day in-person meeting with our Maricopa County partners, a tabletop, to review our plan and to start talking about ideas and how we needed to change things and adjust things moving forward. As Jeremy mentioned, this was really easy to coordinate because we all live really close to each other, and we just all showed up at the state health department for a 2-day meeting. We're now updating our plan based on all the results from that meeting, and we plan to have it done by the end of this calendar year. That means in 2025, we'll go back to our Maricopa County partners, share the drafts with them, get their feedback, and be able to host a 2.0 meeting to share the updates and get Maricopa County's actual opinions and thoughts on how we need to continue adjusting it. Our state and local partners will be able to review our proposed new plan, finalize their roles and responsibilities, and then we'll keep on working on building awareness once we've finalized all that up. That will then let us hopefully in 2026 host a statewide tabletop exercise to practice what this would actually look like. I think the important part here is that we're not waiting until that statewide tabletop to bring our Ryan White Part A partners in. We understand that our local partners in Ryan White Part A are integral to the buy-in of the plan and to the implementation. We don't fund all of the same people, even though there's a lot of overlap. And so having our Part A as part of the process to plan, to develop, and to finalize plans and goals and activities is really important, because then when we get to hosting something statewide with all the partners that all of our programs fund, we have a unified voice and a unified decision on how we're doing things, how we're implementing, and how we can speak to our funded programs, which I think is a huge benefit. Next slide. Finally, a couple of tips and tricks. I know that there's a lot of ways that here in Arizona and in Phoenix, we are set up for success, but I want to be really clear that prior to me and Jeremy being in our current roles, things haven't always been as rosy. There have been times in the past where the state and the county didn't really talk, or there was some tension and there was animosity. And there has been a real concerted effort over the last probably about 10 years to rebuild this partnership, to find ways to work together. And so I just want to clarify, it can be this good, it just takes a little while. Some tips and tricks is to start small, things like working on an EHE plan together, or communicating about a survey to make sure that you're including each other, starting to think about how you're going to build your careware so that maybe one day in the future you can integrate it. We've also built in a lot of consistent and frequent communication touch points. For a while, Jeremy, I think our teams were meeting like every other week. Now we meet every other month because we're in so many other projects with each other that we have one dedicated meeting for just us to chat about anything or grant updates or funding fun. But man, while we were working on the portal, Jeremy and I were on a stand-up meeting every single day at 8:30 for like 6 months. And Jeremy, as he mentioned, he meets with the portal team and the careware team like once a month on eligibility. I meet about integrated planning with his subcommittee members every other month. We're on calls about site visits. I mean, we have so many regularly scheduled meetings with each other that not only do we have those, but we still maintain our check-in that's just to hang out. And I think that's really important because sometimes we get really lost in our projects and our programs that we're collaborating on, and we forget to just have a touch point that's about What's going on? All those other things. And sometimes we'll be on those calls and be like, oh, gosh, we've been working on this project over here, and I should have talked to Jeremy about this because this totally overlaps with this other random thing. And so having a touch point that is not just about a project or a program, but is that it is really just basically a touch point has been really valuable for us, even as we've decreased the frequency because of how often we're meeting on other things. Another option is to really focus on where your integration will most benefit the clients. It can be sometimes hard to deal with competing priorities, but for us, the Ryan White portal, getting an online application that clients could use on their own that empowers clients to do their own eligibility and renewal, we were able to focus on the outcome for clients, and that was a shared priority. The integrated plan, we wanted to develop a plan that meant something to folks and was integrated so that our folks in the community felt seen and heard and weren't confused and overwhelmed by 15 different plans with all slightly different goals. We focused on the impact to the clients. And I think another piece is your funded programs. When we collaborate and coordinate on things like CDR or on our needs assessments or even on the Ryan White portal and all these other amazing things, our training too, we're keeping in mind that because we fund similar agencies and sometimes the same agency, it is so much more valuable for that agency to be getting the same information from the office at the state and the office at the county than to have competing issues, for them to not know if they should say something to us but not to the county. We provide a unified force to them so that they feel comfortable understanding that we're partners, we're in this together, and we both want to benefit them. And I think that's a really important piece to keep in mind. I'll also say we always keep each other informed, even if it takes a little extra effort. And I think one of the biggest pieces is starting projects together, not waiting to bring someone in until you're getting to the end, but actually saying the first part of any project is the buy-in. The first part of the project is deciding what we want to do together, not deciding what we're going to do and then telling this other person what we're going to do and hoping that they'll join us. And so that I think has been a huge benefit. I think that Jeremy and I both work for bosses who go by that sort of motto and that vision. And it's been hugely beneficial here in Arizona. I think we have gone way past our time, so I'm going to stop chatting and I'm going to give it back to the NASDAQ team. But I do think our contact information is on the next slide. Yes, there we are. You can always reach out to us. And if you can't remember which of us does what, we'll communicate with each other on the back end.
Thank you so much, Isabel and Jeremy. That was great. I really enjoyed hearing about all the different ways you collaborate. I think there were some really good examples in there. So thank you so much for sharing today. So we're going to hold the questions until the end of the two presentations, but if you do have a question, feel free to drop it in the chat now, and then we'll address it in the Q&A section. So next slide, please. So now I want to introduce the City of Detroit Health Department Data to Care RX program. Take it away.
Thank you so much, Sarah. And hi, everyone. My name is Fatima Eid, and I'm representing the City of Detroit Health Department. I oversee the Data to Care / Link Up Detroit program, which is really heavy with collaborating with the MDHHS. Today, I will be sharing about our Data to Care RX program, which is our program focused on reaching medical adherence. Next slide, please. So with every presentation that the City of Detroit Health Department does, we like to share our mission, vision, our values. One of our missions is to address public and population health priorities of Detroiters. Our vision is we envision healthy communities where everyone has the opportunity to thrive. And our values are service, transparency, respect, and accountability. Next slide, please. So what is Data to Care RX? Data to Care RX is a collaboration with the Michigan Department of Health and Human Services. So the Michigan State Health Department with the City of Detroit Data to Care program, where we provide outreach for persons living with HIV who may not be medically adherent. So this list comes from the state, and we work together to make sure we can get the clients into care, into making sure that they receive their medication. Next slide, please. So I think one of the terms is like, what does it mean to be non-medically adherent? And sometimes we'll get the question, why wouldn't anyone want to be medically adherent? So in the terms, it's a client who has not picked up their medication within 30 days of dispensary. So if a medication was supposed to be picked up a month ago and they tried calling, they tried reaching, and nobody came to pick up, and then not confirm a medication delivery within 30 days. So if anyone is supposed to receive their medication through a delivery, and usually they call the client to be like, hey, we're outside, are you available? And if that happens like within 3 times, then they become on that list, and then if they have not responded to any outreach, so the pharmacy will call, will try to reach out, try to do whatever they need to do to reach out to the client. So they send them over to us if the client fits any of these categories. Next slide, please. So how does the RX process work? So MDHHS receives a list of those who are not medically adherent from partner pharmacies. Right now we have we altogether have pharmacy partners of 2 within the Wayne County, Detroit area. So anybody that does reside in Detroit or Highland Park or the Grosse Pointe areas, which are part of our jurisdiction, they come to us. MDHS they review the list and they upload the client information, including a note of the pharmacy of why the client's on the list. And usually that ranges: client has not picked up medication, client hasn't been seen over a year. Sometimes it could be the client needs insurance assistance, and which that's what we can typically do. And then once MDHS weans out what is eligible to be on that list, they will send it to us immediately. And then we begin outreach immediately of receiving the list of the clients. So I don't really like to wait, because the longer they wait, it might be harder to find. So usually we'll start that list as soon as we receive it. It could be the same day or at least within the next day. Typically, like what we do is provide outreach through phone calls. We also utilize CareWare. So if there's an updated phone number there, we'll utilize that. We will use like a search database, which is TLO. And we'll go through all the phone numbers that are listed, and sometimes we'll use email. We typically don't send to their house, like we don't send a letter to their house. With our other program we do. And then sometimes we'll do a care coordination with our Ryan White partner agencies. So if a client shows that they're receiving services at one of our agencies, we'll reach out to them and speak to the point of contact, like, hey, have you seen this individual? We're like, yeah. And sometimes they do have an updated number and we get them into care. So once a client answers and confirms themselves, we put them back to the pharmacy and offer as much assistance as possible to ensure they receive their medication. Usually we make sure this is confidential. We don't say like, hi, and say the whole full name. We want to make sure we're just the first name, and then we confirm the date of birth and if they recognize like the pharmacy. So usually like we do get them, like it's been very successful in all the methods that we've done. So once that's all confirmed, and they're like, yeah, and then they're like, and it'll typically be like, I moved, or I switched pharmacies, or I just forgot to call the pharmacy. I had my phone number changed, which usually is like typically what usually happens. Excuse me. Next slide, please. So one of the things is, why is the collaboration important between MDHHS and pharmacies and the local health department? So I think collaborative efforts, provides an all hands on deck approach to ensure that clients are receiving the most optimum care, and most importantly, that they stay in care. For instance, MDHS has the leeway. They are able to build those really strong collaborations that the local health department might not be able to. And because the city of Detroit is huge, like with us, like we can be provided our own jurisdiction to provide the services. Like we can reach that population of Detroit, and pharmacies are always open to reaching clients, to make sure clients are getting in care. Those specialty pharmacies are amazing what they do. For instance, within the past year, we actually collaborated with a pharmacy to provide HIV/STI testing. So providing a really big integrated model is what really gets the clients coming, to make sure that they're receiving their medication, and that any discussion can occur between all entities. Next slide, please. So I just want to kind of provide behind the numbers. This program started way before I started, so 2018, and then over 900 clients have received RX services within those past 6 years. 268 clients were immediately linked back to the pharmacy, which I think is a big win, because we do know it's typically difficult to reach a client. And then 78 clients were linked to a provider to receive their medication. So that also kind of helps with a client who may have a barrier having a physician or a Ryan White agency. And then other clients were unable to locate, which typically happens, and then some have received their medication prior to outreach, which is always great. Some may have switched pharmacies due to reasons of having a pharmacy closer, the delivery, whatever it might work. And then of course, some things are out of our control. So a client may be deceased or institutionalized. Next slide, please. And this is how to reach us. Next slide. Thank you.
Thank you, Fatima. That was awesome. Thank you so much for sharing. I think that was a great example of how a state and a local can work together on a specific program. So next slide, please. And now we'll open it up for some Q&A. So if you do have a question for any of the presenters today, feel free to drop it in the chat. And while you're thinking of your question, I'll give you a little bit of time to type your question in. I'll start us out with a question that I have for Isabel and Jeremy. So my first question you already kind of addressed, which was about the consistent and frequent communication touch points. And I think Isabel really went into this. So thank you so much for answering like what that looks like day to day and in practice. But my other question was about, you mentioned a few times that there's a genuine desire to collaborate and there's a really collaborative spirit and culture. I'm wondering if you have any advice for jurisdictions that may be struggling with this and don't necessarily have that genuine desire to collaborate.
Jeremy, do you want to start or do you want me to?
Why don't you go ahead?
Yeah. I think this is a difficult one because I was really lucky to come into the team about 5 years ago when this pathway had already sort of been laid and had started being walked down. I think that one of the big pieces that really got this moving in Arizona was focusing on a client outcome. So not we need to collaborate because we're supposed to or not because our project officer tells us to, but there is a need because a client might be in both of our systems, especially for Ryan White, to have a unified eligibility for the client. So I think bringing it back to what our programs are doing, which for many of our programs, it is serving clients and participants, I think it really helped the programs at the state and local level here in Arizona get on the same page about implementation of something new. I think that it can often be hard to start collaborating and trusting each other if you don't have something to work on. It's hard to build relationships, and sometimes it's as easy as starting to show up to someone else's meeting and just being there, or put an invite on the calendar, and even if they cancel 3 times, they are there on the 4th one and you chat and you share. I really think that in Arizona, it's been about finding something to work on, not just forcing each other to be best friends. So we don't need to share all of our plans. We don't need to share all of our data, but we have an agreement that this project is important for the clients we serve, or building a training together will better benefit the folks that we dually fund. And focusing on implementing that, creating a program, and having a joint understanding of where we're going together, I think is sometimes easier than just saying, we need to start meeting every week and telling each other what's going on, because that can be really scary and overwhelming. It's hard to just give information sometimes to a program that you don't know and you don't work in. But if you're working on a project that is very clearly going to impact both of your programs, there's a buy-in and an accountability there that I think helps to build trust. And I think that oftentimes when you have a project to work on together, you can more organically build relationships and trust and understanding of each other's programs, not because you're sitting down and just talking at each other, but because you're working through questions and answers. I think my final thing would be to be really consistent. I know that we've built, not just with Jeremy, it's like the county and state here are good. I feel like our project officers show up and they're constantly shocked that when we say we have good relationships, we actually really mean it. But I know here at the state, we've also built relationships with a lot of other folks over the past, 5-10 years. And a lot of it is consistency and showing up and doing what you're going to say. So if you say you're going to have a monthly meeting, showing up to it, even if you know the other person is going to be late. Or if you said, I'm going to include you in the draft version of this document, making sure you actually send it to them. And if they send back comments, telling them what you can incorporate and what you can't. I think the accountability and consistency is really, really important, even if the other person isn't showing up to the table, and which I know can be draining and exhausting and really, really frustrating. But I do think that it's worked here in Arizona, and it's built an incredible amount of trust among our programs. But I'll turn it to Jeremy as well, because he saw this from the county side, and he's also been at the county just a few more years, actually a lot more years than I've been here at the state. It's incredible because he's still 29. Like, how has he been there so long?
Yes, well, thank you. I appreciate that, Isabel. But yeah, I have been with the program now for almost 10 years. And so, but I also I saw some of the building of the relationships, but we were in a very privileged position in Arizona because literally months after I started, my boss, who was not the program manager but was the overseeing quality and admin, went over to become the Part B program manager. And the Part A program manager had been her mentor for years. And so it was already built in this relationship. And then, but I think what Isabel said really was the key. One was it's starting small, finding a mutual project that is beneficial for your clients, but is also beneficial for you, for both your programs, and starting with that, and then being consistent with it, because it's all about building trust. Because I will, in full transparency, we do not always get along. And we don't always agree on the decisions we're making, the other programs we're making, or we're passionate people about this work, and so sometimes when you get passionate people in the room together, it's not always conducive to working together. But I think once you've built the trust, then there's room for like the grace to be able to be like, okay, we can disagree on this, but where can we find a common ground and move forward? And that's what we've done really well together, of pivoting when there's those moments. Okay, how do we pivot from here and continue? In that data sharing agreement, that MOU that I talked about that took like 8 years to build, like we specifically asked for lack of a better word, a divorce clause in there of how, if this doesn't work out, how do we separate these programs and these data sharing? And so you have to give yourself those kinds of moments too, because then again, you allow yourself to build trust, and then there is an out in case there's things, because who knows? I keep saying when I win the lottery, or when Isabel's boss decides to move on to something else, whatever, like, and we get new people in, those things could change, right? But really, because we built from the ground up, and it's been both of our programs have very consistent staffing as well. We've been able to continue that trust. So really, it is starting small, being consistent, finding a common project to work on.
Would definitely echo Jeremy. We're not trying to be the county. The county's not trying to be the state. We don't always have to be best friends. We don't have to agree on everything. I think Jeremy brings up a great point. Find something that you do agree on, and be honest when you don't agree. Like, it's okay that we can say we don't agree sometimes, or we can't share that with you, or you said you don't like this, we're still doing it. That's okay. We run different programs. I think we're honest usually, as much as we can be when we do disagree, which I think helps. But like, don't pick that project that you know is going to be a fight to start with. Start with something you can do together. Yeah, I think Jeremy brings up a great point in that.
That was really great advice. Thank you so much to both of you. And I'll also just say to our attendees, this is something that NASFAD can offer TA with as well. So if you're struggling to start this yourself in terms of relationship building, or where do I even start to work with the state or the local, this is something that, for example, I'm hosting a relationship building sort of meeting in January in Texas. So please feel free to reach out if you're like, I don't even know where to start. Here's the situation. We're happy to meet with you and kind of discuss what that looks like for your jurisdiction. So if y'all have any other questions, feel free to put them in the chat. In the meantime, I'll go ahead and ask a question to Fatima. So if you could share a little bit more about the implementation process for the Data to Care RX program. So where did it kind of start? Was it an idea from the state, or was it an idea from Detroit? And how did that implementation process go?
Sure. So this program was started before me, but it was actually the individual who had my role who implemented this program. She realized there was a need for individuals at who weren't picking up their medication, who weren't receiving, and who were being medically adherent, and that kind of derived from the Data to Care program itself. So with the Data to Care, anybody who is not in care, we would link them to care. So I think she came up with the idea of those who aren't receiving care, or they are receiving care, but they're not picking up their medication or being medically adherent. So that's where that program developed and where it was implemented. And I believe she built a relationship with at least 2 pharmacies. So what's so great about the city of Detroit, like the HIVS section is that there was already like in-house pharmacies, like specialty pharmacies at these Y agencies, and they were really interconnected. So her relationship building was able to get her that connection, and she was able to do it. And I believe she had like the discussion with the state, and if she was working with someone else that also worked here at the City of Detroit Health Department. So that's where the implementation came. It wasn't about like a year or so ago where like the state kind of took over the program to initiate it statewide with other jurisdictions.
Great, thank you so much. And one more question for you. So what does the ongoing collaboration look like? I know you shared a little bit about this, but specifically between Michigan State and Detroit. So do you have any sort of advice or best practices or lessons learned that you want to share in terms of working between the state and the local?
Yes, so I'm very into like having those interpersonal communication skills are very effective and impactful. So I have a really good relationship with the state. Whenever I need something, I can reach out to them. Whenever they need something, they reach out to me. We have our monthly meetings. And we also like if there's any like issue that we're having, like we bring it to the table and like, okay, let's figure out a solution of what works, or like where everything kind of comes in like a neutral standpoint. We just sit, we convene, we're like, okay, like this is not working or this is working. How can we change it? How can we upgrade it? So, and we keep them in the loop all the time. It's not like just a one time, like I'll talk to you once in a month or once a few months. It's always like, let's have meetings, let's connect with each other. And that's what really has been helping. So my biggest advice is really develop a strong relationship as much as you can with each other, where it's easy to call someone like, hey, I kind of need your assistance, and someone can call you for assistance. Because at the end of the day, like we have like the same mission, we have the same goal. We want to achieve success with data to care. And it's always like, hey, we're thinking of changing this up. Is this okay? And then they're like, yeah, like that's fine. So I really love working with our State Department. They've been pretty flexible, been pretty helpful. So I just think like having those really effective communication, building a strong relationship with each other is what really develops a strong connection with each other.
Awesome. Thank you so much. I'm not seeing any other questions, and that's okay. So we'll just move right along to the next slide. So we're going to skip over our group discussion today just due to time, but I will say if you do want to set up a call with NASTAD to discuss your specific situation in terms of your jurisdiction, feel free to reach out after this webinar. And so before we wrap this up, just want to share a few best practices to keep in mind as you're working towards improving your collaboration efforts. We already mentioned several of these, so thank you so much to our presenters for already being ahead of the ball on this one. But just making sure you're keeping the right stakeholders in place. So making sure you're including everyone who needs to be included, and maybe not including some folks who aren't relevant to the process at this time. Sending the right message at the right time, so tailoring your information based on what the stakeholders need to hear. Being as transparent as possible, I think Isabel mentioned earlier, is you want to make sure you're building trust and making sure that everyone has the information that they need. Providing the right level of detail. So some stakeholders might need the super detailed reports, for example, your funders, but maybe public-facing documents don't need to be super detailed. They need to be more high-level. So just keeping that in mind. And providing regular opportunities for collaboration and discussion, which we discussed a lot today, making sure you have those regular touch points in place. And I really like what Isabel said, like, even if there's nothing to really discuss, keeping the meeting on the calendar as relationship building is important too. Next slide, please. Okay, so we're going to go ahead and wrap up for the day. We do have an evaluation survey that's super brief, and we would love if you could take a couple minutes to complete it. My colleague Allison just dropped that link in the chat. There's also a QR code if you would rather scan that QR, and I will include this link too in our email that I'm going to send out after this webinar. So the survey is only 5 questions. It should take you only about 2 minutes to complete, and we really, really value your feedback. So please complete it for us. And next slide. So here's our email. If you do want to reach out for any TA opportunities, like I mentioned, it's eheskip@nastad.org for any questions or any TA requests you may have. So after this session, I'm going to email all of you with the slides, the recording, And it has the contact information for our presenters too in the slide deck, as well as the NASDAQ contact information. And I think there may be one more slide, or is this the last slide? This is the last slide. Okay, well, thank you so much for everyone for joining us today for part 3 of our EHE office hours series. And this is the last part. So yeah, just feel free to reach out to us at any time with any questions or anything, and have a great rest of your afternoon. Thank you so much.
Thank you.